Hello and welcome back to part 2 of the blood vessel or hemodynamics lecture. So I wanted to start right here and just review what we talked a little bit about last time in regards to how the capillaries are going to filtrate or reabsorb liquids between the tissues and the plasma of the blood. So I want to orient you to the arterial. Coming into the capillary bed, we have essentially the capillary hydrostatic pressure. So we have blood pressure coming in under great pressure. This can be measured at 35 millimeters of mercury. So because of blood colloid osmotic pressure, that is the pressure that is drawing fluids back into the capillary because of all the proteins and dissolved materials that are in the capillary, we have blood colloid osmotic pressure is going to be 25 millimeters of mercury. Now, net filtration is where you take and you subtract the pressure from the blood pressure minus the colloid osmotic pressure. So you can see here we get a plus 10 millimeters of mercury. That means there's more pressure that's being exerted on pushing fluid into the interstitial fluid than there is blood colloid osmotic pressure bringing fluids back into the plasma of the blood. So if you see a positive number when you do net filtration, that means that there literally is filtration occurring in blood, the plasma of the blood. Elements of the plasma of the blood will be secreted into or filtrated into the interstitial fluid. So if you go downstream a little bit further, let me take the ink off this. If you go downstream a little bit further, you can see that reabsorption, let me go back one slide. You can see that reabsorption is going to be the thing that's going to happen, and that is because the blood pressure has diminished to 18 millimeters of mercury, but the blood colloid osmotic pressure stayed the same, 25 millimeters of mercury. So when we do the little net filtration calculation, we see that there's a negative number there. That means there's greater pressure going this way than there is pressure going this way. And that basically is going to indicate that reabsorption is going to occur so that some of the interstitial fluid will come back into the blood supply. Okay, so remember, these are just a battle of pressures. We have the blood hydrostatic pressure, blood colloid osmotic pressure, and however those two things interact with each other, we're either going to get filtration, that is fluids moving out, or we're going to get reabsorption, fluids moving back into the blood supply. All right, now I want to talk about some factors that are going to control the flow of blood and also control blood pressures. Lots of different things that can control these particular activities. So for the first thing, blood vessels just in the regional area, there is autoregulation that goes on all the time. So if we have disturbances in homeostasis, disturbances like, changes in oxygen, pH levels are changing, carbon dioxide levels are changing, we have chemicals like prostaglandins, stress, trauma, temperature changes in the local areas. If you get any kind of inadequate blood flow or blood pressure, there are sensors there locally that can respond to those particular conditions. So if we have an inadequate blood flow, we can take those precapillary sphincters. We can decrease the resistance that they provide. That smooth muscle tissue can relax, so there is vasodilation, and this will restore the blood flow and/or whatever you need. So if autoregulation does not restore homeostasis, if there's not any ability for the local things to act, then we need to pull in the big guys. So if autoregulation does not restore homeostasis, we're going to pull in the effector organs like the kidneys, and we're going to pull in effector organs like the nervous system. The nervous system can do all kinds of things. It can sense all kinds of changes and then respond. So it can get you to respond because there are cardiovascular centers in the medulla oblongata. And, the sympathetic nervous system, all of these things can cause vasoconstriction, increase heart rate, increase stroke volume coming out of the heart. And so these can do all kinds of things to increase or decrease blood flow. So, the kidneys can be influenced by the endocrine responses, various kinds of hormones, and this can basically take and and deal with long-term blood volume or blood pressure changes. So then these would be more like endocrine mechanisms that are going to be working here. All right, so let's talk about some of the nervous system mechanisms. We'll talk about the baroreceptor reflexes. So all throughout the body, we have these things called baroreceptors. They're not all throughout the body, excuse me, but they're located in a couple of areas. So they're basically in your aortic artery and your carotid arteries. And there are little sinuses, little spaces that fill with blood that have these receptors. And if you have an increasing blood pressure, these baroreceptors will be stimulated to do their job. So what baroreceptors do is they will signal the medulla oblongata and specifically the cardiovascular system or center, and they're going to basically stimulate. So if we have an increase in blood pressure, they're going to stimulate cardio-inhibitory centers. They're going to inhibit cardio-acceleratory centers. The vasomotor center in the medulla oblongata is going to be inhibited. Now, what this results in, remember, we're basically trying to respond to a stimulus, which is increasing blood pressure. So we want to basically diminish that blood pressure. So by doing these particular activities, it results in a decrease in cardiac output and vasodilation. Both of these things are going to reduce blood pressure, which will get us back into homeostasis. So that's the baroreceptors responding to increasing blood pressure. The baroreceptors can also, if we have a decreasing blood pressure stimulus, those baroreceptors in the aorta and the carotids, they're going to be inhibited. And by inhibiting those at the site of the medulla oblongata or the cardiovascular center of the medulla oblongata, vasomotor centers are going to be stimulated. And these are going to, that results in vasoconstriction occurring. The cardio-acceleratory centers are going to be stimulated. That will accelerate the cardiac output, and cardio-inhibitory centers are inhibited. So we have an increase in cardiac output. We have vasoconstriction. This will increase blood pressure and restore homeostasis. So that's a way that receptors, the baroreceptors located in various arteries of your body, can sense decreasing or increasing blood pressure and basically stimulate or inhibit certain regions of the brain to thus cause vasoconstriction, vasodilation, or increase or decrease cardiac output. All right. Well, we have also chemoreceptors that are different than baroreceptors. Baroreceptors are sensing changes in pressure. Chemoreceptors are sensing changes in chemical composition of the blood. So let's say the homeostasis is an increase in carbon dioxide level, a decrease in pH, and a decrease in oxygen levels. So you might ask yourself, well, what kind of stimulus would signal that? Well, when you exercise, we increase carbon dioxide, we decrease the pH because we're making lactic acid, and we decrease oxygen levels because we're using it in the physical activity that we're doing. So that's the stimulus. So we have chemoreceptors that are located in carotid and aortic bodies and the medulla oblongata. These chemoreceptors are going to be stimulated by this change in chemical composition. These are going to affect the medulla oblongata. One of the centers will be the respiratory center that will be stimulated. So we'll basically increase the respiratory rate when we stimulate that center. The cardiovascular centers will also be affected. So the cardio-acceleratory center will be stimulated. That results in increased cardiac output and increased blood pressure. Cardio-inhibitory centers will be inhibited. Vasomotor centers will be stimulated, which will cause vasoconstriction, which will increase blood pressure. So these particular things, all of these things working together, the increase in respiratory rate, increase in cardiac output and blood pressure, vasoconstriction, these will eventually work to increase blood pH and oxygen levels and decrease carbon dioxide levels. So we restore homeostasis using those chemoreceptor reflexes. So we also have ways of regulating blood pressure and volume using hormones. So this would be kind of like the hormonal response of changes in blood pressure. So let's look at changes of increasing blood pressure and increasing blood volume. That's the stimulus. So we have the heart that has cardiac muscle cells that will release the various natriuretic peptides, ANP and BNP. These are going to go to, these hormones will go to the kidneys and blood vessels, and their response will be an increase in the loss of sodium in the urine. Water will follow that, so there's more loss of water in the urine. The brain will respond by decreasing thirst. There will be an inhibition of antidiuretic hormone, aldosterone, epinephrine, and norepinephrine. This will, and there will also be peripheral vasodilation. All of those things are in response to the release of ANP, or the natriuretic peptides or peptide hormones. So all of these activities will decrease blood volume and blood pressure. Well, let's say we have then, as the stimulus, let's say we have blood loss and a decreasing blood volume or blood pressure. So you can get blood loss, of course, from bleeding or, some kind of wound that you might have. So response directed by the nervous system will be, the hypothalamus and baroreceptors and chemoreceptors. All of these things are going to respond to generally activate the sympathetic nervous system, release norepinephrine, epinephrine. These are going to affect the heart and blood vessels by causing vasoconstriction. That increases blood pressure. There will be a mobilization of the venous blood reservoir by stimulating the smooth muscle tissue of the veins. You can squeeze a little bit more blood into circulation or release it into more general circulation. And there's going to be an increased cardiac output. So that's kind of like the response by the brain and nervous system. So response is coordinated by the endocrine system, including activating your kidneys. The kidneys will basically produce erythropoietin that'll increase blood cell formation. Also, the kidneys will be affected by antidiuretic hormone, angiotensin II, aldosterone. All of these things are going to work together to increase blood volume, as we talked about in the endocrine system lecture. And if we get an increase in red blood cell, increase in blood volume, and then all these other activities, this is going to work to increase our blood volume, increase our blood pressure, so we go back and restore homeostasis. Okay, so those are ways you can control the blood pressure and blood volume. All right, for our last little part for this lecture, I want to talk a little bit about the circulation of blood. And we're talking about arteries and veins specifically. Now, we're going to spend a lot of time in lab working on arteries and veins, like the anatomy of arteries and veins. It's generally hard to lecture on arteries and veins. It's something that really you need to practice. But I want to go over some general flow of things in this particular lecture. This is not an all-inclusive thing, but in lab you'll be working on specific arteries and veins that you need to memorize or to be able to identify for testing purposes. All right, so generally speaking, the heart's in the center here. We do have a pulmonary circuit. Let's see if I can use my highlighter this time. So we do have a pulmonary circuit up here where we're taking blood from the lungs, blood from the heart, taking it to the lungs so it can become oxygenated by the lungs, and then we're carrying that blood back to the heart. So that's the pulmonary circuit of circulation. So we're going to focus on this, learning about the arteries and veins, and so we'll focus on the systemic circuit. The systemic circuit takes blood out of the left ventricle, and it's going to carry that blood through the aorta. The aorta will branch, carrying blood to the upper parts of the body and your upper arms, your arms, and then it'll take blood to the lower parts of your body, feeding all the organs nice, fresh, oxygenated blood. As you're familiar with, we are going to have a place where there are capillaries that connect the arteries and the veins. So these capillaries are going to carry blood to the veins. So once the blood gets to the veins, the blood is then going to travel from the lower parts of the body to the inferior vena cava. It's going to carry blood from the upper parts of the body through the superior vena cava. All of these things will collide in the right atrium. So generally we have, systemic circulation that carries blood to the body, and then we bring it back and to the heart to be reoxygenated. There are lots of capillary beds. So I like this particular graphic here because it shows you the various capillary beds that are connecting all of these areas. So these are all capillary beds that connect these areas in. Okay, so I want to go ahead and I want to start talking about the general circulation, and we're doing arterial parts this time. So we'll start off with arterial parts, and I'll see if I can use the yellow highlighter to help us out here. So we're starting here in the left ventricle, and in the left ventricle we have blood coming out of the left ventricle into the ascending aorta. The ascending, I don't think I like that very well. Let me get a pen, and we'll use black. So the ascending aorta is the vessel coming out of the heart, and it's going to become the aortic arch. Now at the aortic arch, there are basically branches that come off the aortic arch. So we have the left subclavian branch that comes off the aortic arch, and that's going to feed your left arm. We have the left common carotid, which will go up to the left side of your neck and feed your head, or at least the left side of your head. And then coming out of the aortic arch, we have the brachiocephalic trunk. The brachiocephalic trunk will subdivide into the right common carotid, which will be the carotid artery that will feed the right side of your head. Going on down, the brachiocephalic trunk is going to branch into or become the right subclavian. So the right subclavian will come into and eventually feed the right arm. Coming off of that, we have the various vessels that are going to feed various parts of the body. We have the right internal thoracic, the right thyrocervical trunk, and the right vertebral trunk. Okay, those vessels will come off of the right subclavian. So moving on down a little bit further, the right subclavian will become or merge into the right axillary as it goes through the armpit area. The right axillary will merge into the right brachial. Okay, and then the right brachial is going to branch, and we'll see a branching of that in just a second. So the right brachial will form the right radial and the right ulnar, and these will basically go ahead and feed the hand eventually as it goes further down. The right radial the radial artery on both sides is a pretty significant artery because it's usually when we do a pulse, check for a pulse. Okay, now there's a lot of pictures you'll be looking at in lab, and you'll be doing some coloring and things in lab and labeling in lab. But just showing you from a side view, brachiocephalic trunk. We have the right common carotid artery coming off, right subclavian vein coming this way, and then the axillary artery coming this way. Just showing you this, the right common carotid does bifurcate into the external and internal carotid arteries. These will branch and feed the outside of the face and scalp, and then it branches inside to feed the internal parts in the brain. The vertebral artery goes through that little vertebral foramen that you learned about in the cervical vertebrae, that little hole right there. That's just kind of an interesting one because it does feed parts of the scalp and parts of the brain. Facial artery, the face is has a really good blood supply, and because of that, anytime you cut your face, it bleeds a lot. We use our face, to show or communicate by blushing, and we also release a lot of heat through these blood vessels as well. So our head is really well supplied with blood. So we won't learn all of these particular arteries. I just think it's kind of interesting that there is a place or a circle of arteries in the body. It's called the circle of Willis, and you generally can see it here. Let's see if I can use my highlighter here to highlight it, maybe in green so you can kind of see it. that little circle of Willis, sometimes when you get a blocked blood vessel, it doesn't mean that your brain's going to die, because that circle of Willis may be able to reestablish the flow of blood to the opposite side. So that's just kind of a unique little feature of the brain to try to get it to survive some kind of event where you lose blood supply on one side or the other. This is just showing you a little bit about the vessels coming down. So we have the axillary, we have the brachial branching into the ulnar and radial. So now we're going to bring it down on to the lower parts of the body, to the thoracic and abdominal regions. I like these little flow charts. These little flow charts are really invaluable, because sometimes when you just look at pictures of arteries or diagrams of arteries, sometimes you lose track of what's going on. But these little flow charts are really very nice. So if I take a look here, the flow chart's divided this way. So we have the thoracic aorta. So coming down, the aorta curves around behind the heart and becomes the thoracic aorta. Coming off that thoracic aorta, we have blood vessels that are feeding the respiratory passages, the bronchial arteries. We have the blood vessels that are feeding the pericardial. So we have esophageal arteries feeding the esophagus. So we have arteries feeding the diaphragm, arteries feeding the intercostal muscles. Coming down to the abdominal aorta, once we get into the abdomen, then we're basically feeding the stomach, feeding the spleen, feeding the liver, feeding all the internal organs like the intestines. We're feeding the diaphragm and lower portions of the esophagus, the adrenal glands, the kidneys, the testes, vertebrae, spinal cord, abdominal wall. Everything gets fed because we have branches coming off of these major arteries. If we move down here beyond, we basically break into the right common iliac and the left common iliac arteries. Okay, so one goes to the right, one goes to the left, and they go into basically the legs. So once we get into the legs, we have the right iliac and the right external iliac, the right internal iliac. Right internal iliac is going to divide and feed further and further things. Okay, so you can see all the hip muscles, the anus rectum, external genitalia, the hips, the sacrum, all of those things get fed. And eventually those particular arteries, so the common iliac will eventually form the external iliac, which will eventually merge into the femoral artery, which is a major artery, the popliteal artery, and the dorsal pedis. This is kind of a sequence down the midline of the leg that you could go through. Okay, so in lab we'll be looking at all these arteries, and basically, you'll have a certain number that you'll have to learn, but I'll explain those in your lab. Okay, well, the veins are going to essentially bring all the blood back to the heart, to the right side of the heart. So we have a reverse sequence. So, we have going from the bottoms of the feet, we have the tibial and fibular veins. They're going to flow into the posterior tibial, which will flow into the popliteal. Popliteal will basically bring blood in from the small saphenous, and eventually all these vessels are going to merge into the femoral, the deep femoral, the great saphenous, and the popliteal. All of these will become the femoral, which will become the external iliac, which will become the common iliac, and this will flow into the vena cava, the inferior vena cava. So here we have the common iliacs draining all the blood from the legs. These are going to continue going up through the inferior vena cava. All along the way, we're going to keep on bringing blood in from the renal areas, the lumbar areas, the gonadal veins, the adrenal veins, the phrenic veins bringing blood in from the diaphragm. Hepatic veins are going to bring blood in from the liver. All these veins will flow into the inferior vena cava. Okay, so we have the inferior vena cava bringing all that blood to the right atrium. Now also coming into the right atrium is going to be all the blood from the arms and from the head. So if we take a look at the blood coming from the arms, we have the right ulnar and right radial veins. They're going to merge into the right brachial vein. The right brachial vein will merge into the right axillary vein. So we'll also have the right cephalic and the right basilic. These will be also bringing blood from the arms. All this will merge into the right subclavian and eventually the right brachiocephalic. So bringing stuff from the head, we have the external jugular, the right vertebral, right internal jugular. These bring blood into the right brachiocephalic. And you have the right internal thoracic and the mediastinal veins bringing blood into the right brachiocephalic. All of these will bring blood through the superior vena cava into the right atrium. Okay, same thing happens on the left side. We basically bring all the blood in. It flows into the superior vena cava into the right atrium. We also bring blood. Remember, the blood from the heart has to be drained as well. So these things will come in. The cardiac sinus will bring blood back to the right atrium, and then all these other blood vessels are collecting blood, bringing them into the superior vena cava. All right. Well, that's a quick view through the veins. Again, in lab time, we'll be looking at the various veins. So the facial vein drains the face, external jugular, internal jugular are draining the face and internal parts of the brain. Vertebral vein also drains the blood back to the brachiocephalic. So the brachiocephalic is going to collect blood from all these parts up here and from the subclavian and drop it into the superior vena cava. So just showing you, the radial and ulnar veins are picking up blood in addition to the cephalic vein. We have a medial cubital vein. That's one that's important for drawing blood from. A lot of blood's drawn from that. All this blood's drawn from drawn back from the arm. Eventually they go to the axillary and then the subclavian and then the superior vena cava. So all the blood that's drawn from your head comes to that superior vena cava as well. Just to show the most common veins, and we'll be looking at this in lab. And again, you have your dorsal pedis vein, popliteal vein, great saphenous. All these are flowing into the femoral vein, external iliac, common iliac, and eventually inferior vena cava. All right, our last little topic before we finish this up will be the fetal circulation. Now, the fetus doesn't have lungs that are working correctly. Okay, so the fetus, these lungs, basically they're breathing in water because they're in amniotic fluid. So there's really no reason to carry blood to the lungs to become oxygenated, because the oxygen that the baby is going to derive nourishment from comes from this organ over here called the placenta. The placenta is the organ that's going to basically be the connection between the baby and the mother, and that's where the baby's going to get its blood supply. That's where it's going to drop off its waste products, and that's where the baby's going to get its oxygenated blood. So I guess we could start anywhere in the circulation. Let's go ahead and we'll look at the umbilical arteries. Umbilical arteries are going to carry blood to the placenta, okay, through the umbilical arteries. Coming back oxygenated through the umbilical veins, so we have the umbilical veins bringing blood back to the baby oxygenated. You can see it goes through the liver, and then it's going to come into the inferior vena cava. Okay, this is called the ductus venosus that carries the blood from the umbilical veins through the liver to the inferior vena cava. Now, once blood comes into the inferior vena cava, you can see it enters the right side of the heart. Now, you know that the right side of the heart is pulmonary circulation, but we don't really need to send blood to the lungs to get oxygenated because it's already oxygenated from from the placenta and from mom's circulation. So there are a couple of little unique adaptations in the baby's heart here. we have the foramen ovale. This is going to be a hole that is in between the right atrium and the left atrium, so blood can flow directly to the right atrium, from the right atrium to the left atrium through that hole. So literally you have a hole in your heart called the foramen ovale that allows blood to flow from the right atrium to the left atrium. That's important because the blood's already oxygenated. If it goes directly from the right side of the heart to the left side of the heart, it can be squirted to circulation. Okay. Another little adaptation, let me get this ink off. Another adaptation in fetal circulation is that if blood does go to the right ventricle and is squirted through the pulmonary trunk, there is an additional hole called the ductus arteriosus that is open, and that allows blood to flow directly into the aorta. So you have oxygenated blood that can flow from the right side of the heart to the left side of the heart through the foramen ovale. Then we also have blood that can go directly from the pulmonary trunk to the aorta. Let me go back and get my pen. We have blood that can go directly from the pulmonary trunk to the aorta through the ductus arteriosus, as long as it's open. That helps to bring fresh oxygenated blood to all the parts of the baby's body, thus bypassing, for the most part, sending blood to the lungs. Now, when you're born, that foramen ovale will close up, and there will be a little depression there left over. Sometimes people are born with that not closed, and they might have to surgically go in and close that. So you also have in the pulmonary trunk, you have the ductus arteriosus is closed up, and it leaves like a little ligament there connecting those little vessels together, a little connective tissue connecting those vessels together. Okay, so those close up and allows for adult or normal, postnatal circulation. All right, so you always want to make sure you remember that no system is isolated from any other system. Everything is part of all the other systems. So this is basically showing you how the cardiovascular system is involved with all the other systems. It's kind of crazy when we go to the doctor's office and get treated. Typically, doctors only treat you for one condition. They don't ask you anything else about any part of your body. I guess that's efficient, and I guess they make a lot of money from that, but it's not how the human body really is organized. No system is in isolation of any other system. So, if you go to some kinds of doctors, they take a more holistic approach to the human body, and they basically, when you come in with certain kinds of conditions, are going to look holistically at your body, not just at one particular kind of symptom or sign. So maybe that's a trend in the future, is kind of understanding that the body's not in isolation and that we need to look at multiple systems and the effects on multiple systems and how they're working with each other to really establish health and understand how diseases are really working. My last little thought is that the circulation of blood is really important. If you look at the emergency trauma assessment, many of you will learn this assessment, but when you come up to a person and you are assessing them, you will basically go through the A, B, C, D, E, F, Gs, and A stands for airway, because if a person's not breathing, they are dying. Okay, so you look to see if they have an unobstructed airway. When you go to the B, that means breathing. So if they have an airway, are they breathing? If they're not breathing, you got to breathe for them. But if you notice the third, so this is showing this is really important. Circulation is really important, because if you're not circulating blood, then you're not getting blood to oxygen and nutrients to your brain and to your heart, and that tissue dies really pretty quickly. After we do circulation, we look for any kind of disabilities. Then we can examine other kinds of aspects, take temperatures, get vital signs, do a head-to-toe assessment, and then we can basically begin to do an intervention and treat what's wrong with the actual person. These A, B, C, D, E, F, G, H, I's are really important to learn, because if you are an EMT, a paramedic, a nurse, a doctor or physician's assistant, you should be able to learn how to assess very quickly your patient, and so that you can help them to live and survive, especially if they're unconscious. Okay, well that concludes part 2 of the circulation, the blood, um, and hemodynamics lecture. So I hope you learned a little bit of stuff. Make sure you do all your reading, make sure you do all your study guides, and keep up with all your work. And next time I will see you, and we'll be talking about the immune system. So until then, I wish you a good day or a good night.